he is leading the one of the largest associations of critical care physicians, and he has been also the ASEAN specific representative for ESICM or European countries. And he has been in the forefront of many academic seasons, and including he's been a teacher, academician, leader, mentor, many more. So we are proud and happy to have you, Dr. Rajesh Mishra, sir, on board. Thank you to join us. And we have Dr. Saroj Prusty, a senior clinician, internist, intensivist, and leading the Department of Critical Care Medicine for the last decade or so. He is on board to take us through an interesting case, not commonly encountered in medical intensive care unit, but more so in the cardiac units. Occasionally, we get through this infective endocarditis being a part of it, and to that, we have two youngsters who will present the case. So over to you, Sahitya, for the presentation. Thank you, Sasi.
Good evening, all of you. So today we'll be presenting a case of a 16-year-old male patient. He was a resident of Somalia. He came with complaints of fever since 5 days, dyspnea since 2 days, body pains since 2 days, severe myalgia since 2 days, and right upper limb vesicles and edema since 2 days. He presented with these complaints to the ICU. History of present illness: patient had complaints of fever since 5 days, which was continuous in nature and high grade. The maximum temperature which reached was 102 Fahrenheit, not relieved by medications, and there was no diurnal variation. Was associated with myalgia. He was unable to lift his bilateral lower limb and upper limb due to severe pain and edema of the right upper limb and vesicles, which started in the last 2 days. It was localized to the ventral surface of the forearm. He had dyspnea from the last 2 days, which was gradual, progressive in nature. It was not associated with cough or not associated with sputum production. With this complaints, he was presented to ICU. He was shifted from ward to ICU with these complaints. The background history of this patient: the patient was detected to have TALL in the outside hospital when reported for loss of appetite, fatigability, and testicular pain. He happened to have this symptom for 3 months of duration, after which he was detected to have TALL. Patient was in follow-up with the oncologist in our hospital. So he was planned for 6 cycles of induction chemotherapy initially. The first chemotherapy which was given was in December, and he had episodes of febrile neutropenia post that. Subsequently, there was Klebsiella in the blood culture, and he was treated accordingly in the ward. The second chemotherapy was uneventful. The third cycle of chemotherapy, which was taken on January 4, 2022, he was shifted to ICU post that. The chemotherapy was with daunorubicin. He was shifted to ICU on 11th Jan in view of the worsening of the same complaints, which was fever, dyspnea, fatigability, and right-sided upper limb vesicles and edema. On examination.
Just wait.
Yes, sir.
Just we can go a little bit back, please.
Yes.
One more slide. So, if I interpret the case, the patient has history of ALL, has taken 3 cycle of chemotherapy.
Yes.
And on 3rd cycle of chemotherapy, one episode of fever he had where he has grown Klebsiella, treated, and now again he has same problem. So a person who is taking chemotherapy has a high grade fever for 5 days.
Yes, sir.
And along with that, there is a general constitutional symptom like myalgia, which happen with every fever, bilateral upper severe pain. That means patient's muscles is getting involved. He has swelling in upper limb and vesicles. So if somebody comes to you with a background of high grade fever, chemotherapy taken, and high grade fever with skin involvement and constitutional symptoms which are out of proportion. So my first question is, did you take this history where symptom more than signs like body ache, pain,
Yes,
myalgia, were those out of proportion to the signs and whatever?
Yes.
Like he has fever of 102, but his symptoms were. So if I make a brief case summary, a high risk, a patient who is on chemotherapy comes to you with high grade fever and symptom out of proportion to sign, that is a high grade myalgia and with skin lesion. what are the probable differential diagnosis of infection you will keep in mind?
So the first thing, if at all the symptoms are disproportionate to signs, would be necrotizing fasciitis is something we have to keep in the mind. If there is disproportionate pain, the symptoms are disproportionate to the signs. Or skin and soft tissue infections, especially in the case of neutropenic sepsis patients. If at all he's post-chemotherapy and he's manifesting signs of infection, then it must be a case of neutropenic sepsis, the most common organism being Staph aureus, which is the culprit for most of the skin and soft tissue infections.
So, Dr. Prusty, you can take over.
Yeah. So any other differential diagnosis besides the skin and soft tissue infection at this point of time? From the history, now you have taken the present history of present illness and the past history. So basing on before going to examination, what are the other things differentials you should think of it? So one is necrotizing.
We should think of tropical diseases also. Sir.
So one thing is chemotherapy related.
Okay.
Chemotherapy related because he is having fever and severe pain, severe myalgia. Tropical diseases like dengue, scrub typhus, all those things also have to be kept in mind along with skin and soft tissue infections.
Okay.
And also because he has very severe pain of bilateral upper limb and lower limb, chemotherapy related rhabdomyolysis also has to be kept in mind.
Yeah. Okay.
And then muscle, if he has that severe myalgia, polymyositis, dermatomyositis also has to be kept in mind because he does not have any background of any autoimmune disease, we do not know. So that has to be kept as one of the differential diagnoses.
But are there skin manifestations, dermatomyositis or whatever, or, are there skin manifestations are there to say dermatomyositis?
No, so there was only vesicles over the bilateral forearms, no much of other manifestations or ecchymosis or any other hemorrhagic manifestations.
Okay.
Picture of that skin lesion, do you have picture?
Sorry,
skin
sir?
lesion.
You have images of
So we don't have
no,
the pictures.
Okay, fair enough. No problem. Please go ahead.
On examination, the airway was patent. Breathing, the saturation was 98% on 2 liters of oxygen when he presented to us. The respiratory rate was 24 per minute. Bilateral equal air entry, and there was no adventitious sounds. Circulation part, the BP was 99 by 56 mmHg. Pulse was 103 per minute. Normal sinus rhythm, and all peripheral pulses felt. CRT was less than 2 seconds. Normal S1 and S2 heard. Disability, the GRBS was 90 milligrams per DL. The pupils were bilaterally equal and reactive, and he was moving all 4 limbs, even though he had a very severe pain while moving it. Exposure, right-sided, there was a PICC line which was...
Just wait for a moment. Since how long this right-sided PICC was there?
This was there from the second chemotherapy itself, sir. That was December, almost from December 20th it was there.
So actually, no, okay, fair enough. Now, can you tell us the specific diagnosis, what you will think in this patient with fever and PICC inside with chemotherapy?
CLABSI, that is catheter-related bloodstream infections, would be more common in the neutropenic patients, especially post-chemotherapy. So because there was a PICC line which was placed for a longer period of time, that can be one of the differential diagnoses.
So what will be the most common organism in PICC?
Staph aureus is the most common one.
Okay.
And then cons also can be there, that is Coagulase negative staphylococci also.
Then?
Candidemia, candidial fungal infections. Because he is a neutropenic patient, so we can expect with a longer duration of
it will come on 9th, 10th, not on 3rd, 4th.
More than 2 weeks of febrile neutropenia, fungal infections can be there. Then Enterococcus and Streptococcus viridans.
Okay.
All the normal skin flora can be the ones which might cause this blood-related skin infection, sir.
Like?
Enterococcus is one of it.
You told already. Enterococcus is not skin commensal.
It's not skin flora, from urological tract.
And patient had a past history of Klebsiella in the blood culture. Actually.
Yeah.
Gram negative.
Yeah.
Sorry, what apart from the usual what you are telling, look into the history of PIC and look into the history of chemotherapy. Anything else would like to enumerate?
Aerobic gram-negative bacteria like Enterobacteriaceae. Like already he had a history of blood culture Klebsiella. So Klebsiella or E. coli or maybe resistant microorganisms, gram-negative ones.
Okay, go ahead, please.
Exposure, there was right-sided PIC line which was present, and right-sided upper limb vesicles were present on the ventral surface of forearm. Bilateral upper limb edema present, and the temperature at the time of presentation was 102.
Can you tell me why you people are so repeatedly saying vesicles? And if you are saying it's vesicle, where there's something characteristic, because every time symptom was there, sign were there. So what the vesicles were like? How many vesicles? What were the characteristics of vesicle? Did they look infected? They were inflamed. There was a pus inside, or there was some inflammation only. What kind of vesicles they were there? Because what happened in exam, this is called Abel Mujemar. You are repeatedly, persistently saying vesicles. So where, if you are talking about vesicles, means you should know everything about vesicles, because it has a differential diagnosis. So what were like that?
Sir, they were vesicles over the, almost 4 to 5 amount of vesicles in the ventral part of the forearm. That was the same area where the PIC line also was placed. We removed that PIC line once the patient came to ICU. That converted into blisters the subsequent days.
Okay.
And it was more over the right-sided area. So we attributed that to the initiation of the line, the central line related, because it was not all over diffuse. It was localized into a particular area.
So if it was so characteristic, you should have taken a picture of that.
Yeah.
Because it may have a relation with the diagnosis. Did you send culture for that?
Yeah, so we had sent cultures for that. Once there was like blisters.
And not from the catheter side, you did not take any culture?
Yeah, so catheter side also we have taken culture.
Okay, fair enough.
So,
go ahead, please. Yeah, please.
Yes.
You're saying something, Tejasree?
Nothing, sir. We have sent 2 sets of cultures from peripheral vein and one from the PIC line.
No, I'm talking about the side, vesicle side. Did you take culture or not?
Yes, so we have taken.
Did you take culture from
We have
vesicle or not? Fair enough.
Yes.
Okay.
Systemic examination, CVS examination, there were no murmurs heard, S1, S2 present, and abdominal examination was normal. There was no tenderness. CNS, he was moving all 4 limbs, but there was profuse pain present, or there was no sensory deficit, so there was no cranial nerve deficits, no bowel or bladder incontinence which was present. Investigations. On arrival, this was the ABG of the patient, and that was the chest X-ray of the patient. Initially, when he entered to ICU, there was PO2s were less, type 1 respiratory failure, which was 52.2, and lactates were 2.5, hemoglobin 7.4, and the bicarb was 21.6. That was the chest X-ray of the patient.
Just ABG, just wait.
Yeah.
So what is this ABG like?
So this was metabolic acidosis, which was compensated with there was a respiratory compensation with type 1 respiratory failure and increase in the lactate, which was 2.5.
So what is the cause? What is the cause of dual metabolic acidosis, where there is a metabolic acidosis with respiratory alkalosis? So what is the cause?
Alkalosis.
So sepsis.
If you are given this ABG, what is the most common? There is a also hemoglobin is low. There is not much of an iron gap. Okay.
Oh, no.
And the sodium is also potassium.
Sodium
Right.
is 133.
Yeah. So dual metabolic defect, acid-base defect. What is the most common cause? Why this patient has this problem?
Sepsis.
pH-wise it looks okay, but it's not okay. Patient is in bad shape.
Sepsis is the most common cause, so like metabolic acidosis, neutropenic patients with metabolic acidosis.
So sepsis is the common cause. So
One more is
No.
pneumonia, where patient is trying to breathe.
okay. It is X-ray normal, just X-ray.
Sir,
So there is a
X-ray
hazy,
normal?
there is a haziness in the lower and middle zones.
What
of
about
the,
cardiac shadow? What about cardiac shadow? Is cardiac shadow okay?
it looks like there's a
like
cardiomegaly
a
in the
valley.
X-ray, sir.
Is there anything abnormal in chest shadow? X-ray? I mean lung shadow?
Let's
Are you
see.
sure there was no murmur?
There was no murmur which we made out, so there's no murmur.
What was the heart rate of the patient?
103.
sir.
Huh?
102.
Yeah, so 103 was the heart rate, 90/60 was the BP.
Okay, go ahead, please.
There were 2 sets of blood cultures which were sent from the PICC line and the peripheral vein, and antibiotics meropenem and vancomycin were started empirically. Blood samples were taken for complete blood picture, liver and the renal function tests. Fluid resuscitation was done and the map was targeted more than 65 mmHg. Echo was done for the patient at the same time, which was showing right-sided ventricular thrombus, and there was a new onset tricuspid wall vegetation and regurgitation. The upper limb Doppler was done because of the severe pain which he was complaining in the right side. It was suggestive of right-sided cephalic vein thrombosis. The PICC line was subsequently removed.
So why did this patient had right ventricular thrombus and right tricuspid vegetation?
Sir, we were suspecting initially to be neutropenic sepsis, and then we thought the line of the diagnosis is going towards septic thrombophlebitis, because of which there might be a right ventricular thrombus and then infective endocarditis.
So again, I'll come to the Dr. Saroj, please.
Yeah. So before going to evaluation, so any other things to think of from the examination point of view and from the history, whatever you have taken. I think the thing besides you told that one is CRBSI, another is necrotizing fasciitis, myositis, and cellulitis. And any other thing besides that is because patient presented with breathing difficulty, you have done the chest X-ray. Any other thing at that point of time you should think of it as a DD, differential diagnosis.
Pulmonary embolism also can be one of the differential diagnoses.
Yes. Yeah. Okay. So in the line of when you did evaluation here, so how you sent 2 sets of blood culture. Till that time, you didn't know that patient is having infective endocarditis. So after the echocardiography, you found that patient is having vegetation.
Yeah, sir.
Okay. So before going to the echocardiography, on what background will you suspect infective endocarditis in this patient? Means with the same background, you have taken the history, you have examined the patient, and you have done the things. So with this background, so how will you suspect the infective endocarditis? What type of presentations will help you for diagnosis of or a suspicion of a infective endocarditis?
So patients who are immunosuppressed,
okay,
especially who are on chemotherapy,
yeah,
or who are very well versed for skin and soft tissue infections, in which MRSA would be very common.
Yeah.
And also patients who have a history of predisposing heart condition or an organic heart wall disease, which this patient does not have.
Yeah.
but then who has any organic heart wall disease, which is a predilection for a adhesion of the MRSA organisms. So in those conditions, we would think about endocarditis.
And but besides the immunosuppressed condition, any other predisposing factor is there in this case?
No, sir. He doesn't have any congenital heart disease. He doesn't have any previous history of infective endocarditis. Nothing, sir.
Yeah. But your central venous cannulation, central venous means PICC line itself is also a
Nidus for the
It
infection.
is a risk factor.
risk for infection. And that
to actually make the list more concise, what are the risk factors? Cardiac, non-cardiac, other general risk factors for a patient to give you a suspicion of a endocarditis?
Cardiac causes like congenital heart diseases, prosthetic valve, previous prosthetic valve, or previous history of infective endocarditis. Patients with intravenous drug addicts, these patients we can suspect infective endocarditis. Even in a previous history of any history of staph aureus infections previously, bacteremia, staph aureus bacteremia, they are more prone for the infective endocarditis.
So any devices in place?
Yes, sir.
ICDs in place or pacing devices.
Yes, sir.
So
Pacemakers in place.
Defibrillators, intracardiac defibrillators, PICC
Yes, sir.
lines, arterial lines, central lines, any chemo ports, any devices in situ in place can also increase the risk. You said intravenous drug users. Anything else? Any other surgical procedures also considered to be a high risk in and around with this? For infective endocarditis, the patients who undergone a recent surgeries who are in high risk for this.
Any peripheral vascular disease patient underwent surgeries?
Prosthetic wall, I mean wall replacement surgery.
No, that cardiac is over, non-cardiac surgeries.
So let me simplify it. What are the causes of right ventricular infective endocarditis? And what are the common organisms? The cause for cause for right ventricular endocarditis is different, and causes for left ventricular endocarditis is different. So left-sided infective endocarditis, you need to have some lesion at the endothelium, that is valvular lesion. While on right side, the pressure is low. So even native valve endocarditis can happen on right side, but there should be a risk factor. In your case, the risk factor was PICC catheter. But what are the other risk factors which causes right ventricular endocarditis or right-sided endocarditis? Mainly it is tricuspid, very rarely it is pulmonary. So right-sided tricuspid wall endocarditis in native wall can happen, but there should be some precondition. So in your patient, the one condition was PICC catheter. What are the other common causes for right-sided infective endocarditis?
Pacemakers, sir. ICD, sir. Central venous catheters.
ICD means?
Implantable
Cardio defibrillator. Defibrillator.
Okay.
And congenital heart diseases also, sir.
Any organic tricuspid wall disease?
Yes, sir.
You are missing the most common cause.
Any line place, central venous catheters, sir.
Dialysis catheters.
Dialysis.
You are missing the most common cause of the right-sided infective endocarditis.
PA catheters, which are being placed.
IV drug users, sir.
Pulmonary artery catheters.
IV drug user means
drug users.
Common
IV drug users.
Yeah, because that's one thing which have. So whenever people take multiple infected, particularly, so what happens? There is an infective septic thrombus which is infected. It gets stuck to the right-sided tricuspid wall of ventricle, and thrombus is formed, and that becomes source of the endocarditis. That's why on right side, even the native wall is healthy, it can still have endocarditis because in high risk factor, because of the low flow, low pressure, and with associated risk factor. So this thing you have to understand. Same thing do not apply for left side. For left side disease, you need to have a precondition of inflamed, damaged endothelium or damaged wall. Then only bacteria can stick to the endothelium and then can form a film, and then endocarditis happen. So that's a basic difference between right-sided. So as an intensivist, you must know, because left-sided endocarditis is not a case which comes to you commonly, but right-sided endocarditis can always come, and it is more dangerous, more deadly, and difficult to treat.
Yes.
And what will be the commonest cause for the right-sided endo? Again, coming to the right, because the drug abuser, apart from usual, these patients share syringes and everything. So always keep atypical bugs, always keep negative, gram-negative, this aerobic organism along with gram-negative. So can you enumerate the list of gram-negative bacteria which can cause endocarditis?
HACCP group of organisms which are present.
Enumerate HACCP meaning?
Haemophilus, then Eikenella, Kinganella, and Cornybacterium. And
Coxiella, Legionella, Brucella.
No.
HACCP.
Asking HACCP group.
Sorry.
A is some isn't or something.
Aggregator vector.
Aggregator vector.
C for?
C is Cornybacterium. E is Eikenella and K is Kinganella.
Okay.
And then non-HACCP aerobic gram-negative organisms also are present.
Like?
Klebsiella is one of it, Enterobacteriaceous species. Then Coxella burnetii. Listeria, Legionella.
Brucella.
Brucella.
Do you think these are common for right-sided vulvar endocarditis?
No, sir.
These are mostly left-sided prosthetic wall.
Yes, sir. Yes.
That also more than 1 year of prosthetic wall, these gram-negative aerobic bacillus are more common.
So how to suspect, suppose your how they will present. So only your fever and your this presentation, your pre-morbid condition means predisposing factors, if sufficient enough to suspect the infective endocarditis, or something other presentations will help you for suspecting a right-sided and left-sided. So there are different presentations for left-sided and different presentations for right-sided. So what are the other clinical signs and symptoms from which you will suspect a left-sided infective endocarditis and from which you will suspect a right-sided infective endocarditis? So
sir, in a left-sided infective endocarditis, a patient may present with splenic abscess, multiple embolic stroke, as a stroke also they can present. So,
right-sided, mostly it might be septic pulmonary nodules or pulmonary embolism.
Yes.
And left-sided, because it's more of systemic circulation, CNS emboli, ICH, splenic abscesses, peripheral emboli, or coronary embolism. All those things are more common in the left-sided endocarditis.
Okay. And besides that, if somebody is having a septic arthritis or meningitis, pyogenic meningitis, or osteomyelitis, or renal abscess,
peripheral arthritis,
peripheral abscesses. So usually, along with some predisposing factors and with the fever, this presentation, so then you are suspecting a left-sided. So from that, your pulmonary infarcts or pulmonary embolism, if patient is presenting with chest pain and typical signs of pulmonary embolism or pulmonary infarcts, along with predisposing factors and fever, so then you are suspecting a right-sided endocarditis. So then first, further, how will you approach for further evaluation and to confirm your diagnosis?
Blood cultures would be taken, sir, like initially.
Yeah.
First,
3 sets minimum has to be
there
taken.
has to be at least 12 hours apart, 2 sets of blood cultures have to be taken, or else more than 3 blood cultures. The first one and the last one, the difference being at least of 1 hour. At least more than 2 blood cultures positivity has to come, which will be in compliant with the IE, the organisms.
No, you tell me there are 3 groups of patients. One is sepsis, another one is CRBSI, third group is infective endocarditis. Okay, so the blood cultures will be different. So how to collect the samples in these 3 groups? Is there any difference?
So CLABSI, for suspecting CLABSI to collect the blood cultures, there are 2 sets of blood cultures which you have to take. One has to be taken from the CVC if it is present, and the peripheral line. That is 2 different sets has to be taken.
Yeah.
And in the CVC, it has to be 2 lumens, that is simultaneously from the 2 lumens of CVC and then the peripheral line. And the differential time to positivity, if it is more than 120 hours, then it is defined as CLABSI.
No, that is for diagnosis interpretation. But how to collect the sample? How to collect the sample?
10 ml of a sample has to be collected for the blood cultures.
Yeah.
And for infective endocarditis.
Is there any time gap or simultaneously?
Yes, sir. 30 minutes gap between each of the blood culture bottle to be taken. The blood sample, whenever it is taken, in between that, minimum of half an hour should be there, 30 minutes.
Where? For which you are talking?
Infective endocarditis.
No, I am asking. Now you are discussing regarding the CLABSI.
Okay.
CLABSI is simultaneously 2 sets of peripheral, one peripheral and one CVC, both has to be taken, sir. 10 ml of blood has to be taken in the culture bottles. 2 sets should be there, aerobic as well as anaerobic.
So I have a very specific question. Why do you need to give gap in collecting blood culture?
In case of infective endocarditis, sir?
Yes. And what type of infective endocarditis we are discussing? It is a SABE or it is acute bacterial endocarditis?
Acute bacterial endocarditis.
So when we are discussing about acute bacterial endocarditis, why do you need to give gap, time gap? Do you have time to give time gap? So what is the difference between fulminant acute bacterial endocarditis, acute bacterial endocarditis, and subacute bacterial endocarditis?
Acute is in the first 3 months.
Subacute, usually we see in the left-sided infective endocarditis where the presentation will be later, very slow presentation. Usually they come with the embolic strokes or splenic abscess, then we get evaluated. So usually left-sided.
Did you read these 3 entities ever?
Acute and subacute we have read, sir.
So go and read it.
Yes.
Don't explain. If you don't know, learn to say no and learn it. If you will make a habit of, so bolte hai na, trying to do the collateral, then you will learn wrong thing. So the teaching classes, you should say that, okay, you don't know, and then you will learn and it will be impactful. But there is a specific reason to ask this question. When you are the moment you are saying septic, this patient has sepsis. He has got dual metabolic defect. He's got metabolic acidosis, respiratory alkalosis. He's tachycardic. He's feverish. He's hypotensive. The source may be any, but he is sepsis. So when somebody has acute bacterial endocarditis, not definitely fulminant, but it's acute bacterial endocarditis. So the time gap question is not there. You have to take 2 sets of blood culture immediately and start antibiotic. If you want to wait, in SABE, you have enough time. Patient is stable, intermittent fever comes because intermittent showering comes. And that's why you give 1 hour time. That is a high chance that if you take sample 2 hours apart or 1 hour apart, 2-3 samples, the chances of picking bugs are high. But when patient is sepsis, that principle doesn't apply. So you need to learn this thing and then understand the principle behind taking blood culture, why there's a gap in SABE and why there is no gap in acute bacterial endocarditis. And fulminant infective endocarditis is also in TT, which is rapidly fatal, you must know. Okay, go ahead, please. So you will not do give the gap in taking culture, you will take culture immediately. Preferably 3 sets. I will prefer 3 sets, not 2 sets for endocarditis, because chances of getting positive culture will be high if you take a larger amount of blood. So if you take 50-60 ml of blood for culture in 2 different sets, particularly aerobic and anaerobic, that's sufficient. But you should always take, nowadays backtech systems are available. You need to take blood culture in both aerobic and anaerobic, preferably 60 ml. And how much backtech aerobic and how much anaerobic takes in culture? How much blood you can put in aerobic and how much in anaerobic? इसका मतलब आप लोग कल्चर नहीं लेते हो या कल्चर लेते हो तो स्टाफ लेता है, आपको कुछ मालूम नहीं.
20 cc.
आप चैट बॉक्स देख के आंसर मत करो बेटा. If you know, then you know.
No, sir. I have seen a sister taking 20 cc, one in 10 cc in aerobic and 10 cc in anaerobic.
So you have seen, I mean, 100 people doing wrong thing doesn't become right. You must know how much blood culture in backtech system you have to take in aerobic and in anaerobic. I mean, these are something which basic. If you do not know, how will you teach your staff? Oh, that is written also in bottle. Now things are becoming everything automatic. Just take out your common sense and see how much blood has to be put. There is a specific reason for that. Okay. मैं आंसर तो नहीं बताऊंगा, बट क्वेश्चन आप लोग प्रत्येक बेसिक, आई मीन आई एम नॉट आस्किंग एनी रॉकेट साइंस, जस्ट आस्किंग बेसिक डे टू डे क्वेश्चन व्हिच यू डू एवरी डे, बट दिस ऑल थिंग यू मस्ट नो. Dr. Saroj, anything wrong in that?
No, sir, 100%, because there is an absolute amount of blood is required for what type of blood culture. Sir is asking for a reason for that actually. So suppose you are taking a blood culture, there is a shortage of blood for something sample for a anaerobic culture, then you should not take that small quantity into the anaerobic culture. So you should take a full quantity for that to fulfill. Otherwise, you have to put all the blood into the aerobic culture. So sir is asking for some reason why it is important to know the blood.
Okay, so this is your echo finding. Is it photo or it's live?
It was a photo of that, I mean,
Okay.
whenever we had taken the echo, sir.
Okay, fair enough. Go ahead, please.
The initial labs, the hemoglobin was 7.7, WBC was 3000 with an absolute neutrophil count of 2.70 into by millimeter cube. Platelet was 11,000. Peripheral smear was showing a leukopenia and shift to left, neutrophilic shift to left. Toxic granules were present and cytoplasmic vacuoles were seen with 11% of band forms. Liver function test, the total bilirubin was 1.1. And
so,
the other,
the slide is not moving for me. It's moving for you. Okay.
Yeah.
Fine.
Yeah.
The hemoglobin, WBC, platelets, and the peripheral smear reports. Next slide, the liver function test, the total bilirubin is 1.1 and other parameters were under normal range. The SGOT, SGPT, ALP, everything was under normal range. Renal function tests were also under the normal levels when the patient presented. The procal was done, which was 1.50. D-dimer was 7,565 and the plasma fibrinogen was 120.
So why did you do PCT?
Procal stone.
Why did you do that?
To see the, I mean, whether the patient was actually, the patient was in sepsis only, but then.
So were you right in doing PCT?
No, sir.
So what is the implication of doing PCT in this patient?
Because the patient is immunosuppressed, the procalcitonin might not be that high for this patient. I mean, the inflammation might not be high in this patient.
So why do you do procalcitonin in your day-to-day practice? What is the indication to do procalcitonin?
For de-escalation of antibiotics, so not for the initiation of antibiotics or not for the diagnosis of sepsis, but for de-escalation of antibiotics when you already started, just to see if there is ongoing sepsis or not.
So why did you do here? Waste of money to the patient and resource misutilization. Did you do urine test for this patient?
Yes, sir. Complete urine examination was done.
Show me. Where is the result?
I have not included that slide, sir. It was normal only, so I haven't included the slide.
So what do you expect the urine would be like in this patient?
We need to see for the proteinuria.
Sorry?
If at all.
Any kind of. First, a urinary tract infection has to be ruled out, so that's why the CUV would be done, because that is the most common one.
What do you expect in this patient in urine examination?
Microscopic hematuria we would be expecting.
Yes, sir.
Okay. Anything specific in microscopic hematuria which substantiate the diagnosis of endocarditis?
CAS in the urinary CAS.
What you will suspect?
So in the immunological phenomena, glomerulonephritis might be common in the case of infective endocarditis. So we might see any RBC CAS if they are present.
Okay.
But it was not there in the urine.
Might not have seen, because if you see, you find. So people don't, most of the time platelet count is so low, it's unlikely that glomerulitis would be not there. So infective endocarditis, glomerulitis is a common feature, but very commonly missed much before it causes renal dysfunction. It causes, because the endothelium structure is almost same and glomeruli are full of endothelial structure. So if you have endocarditis, you will have glomerulonephritis. And if you examine urine carefully, but many times there's one way to pick up endocarditis as a source of infection if you're not getting any to look for urine. That's why urine examination in eye is very, very important. Okay, go ahead, please.
Day 2, over the next 24 hours in ICU, patient showed progressive deterioration. He was requiring the increased oxygenation from 2 to 8 liters per minute, and he was started on NIV. So the patient was wheeled to CT chest because of the increased oxygenation. We wanted to rule out if there was any pulmonary embolism or any other infiltrates. It was negative for embolism, but it reported bilateral parenchymal and subpleural inflammatory nodules, which were septic pulmonary emboli, which was reported. This is the CT images. The patient was started on NIV on day 2.
Again, I have a question. Why CT scan?
Because of the increased oxygen requirements, we wanted to rule out pulmonary embolism. Yes, sir.
So
other causes of type 1 respiratory failure.
I mean, what else you need to suspect? And if it is pulmonary embolism, it was CT pulmonary angina, CT thorax.
CTPA was done, sir. CTPA completely it was done.
आपको मुझे CT वो दिखा रहा है. CTPA नहीं दिखा रहा है.
This was the positive finding actually. I mean, the CTPA images I have not included, sir. This was the septic pulmonary nodules which I have included. That the lung window I have included.
So just tell me, if somebody has infective endocarditis, right ventricular clot, patient becoming hypoxic with septic endocarditis, so what value CT scan is going to add to? Or will doing CT scan harm the patient anyway?
First, for embolism, we need to rule out, but later on, because of the contrast, they may land up with the contrast induced. But primarily, first embolism has to be ruled out.
We primarily wanted to rule out embolism only, sir, for the patient. because there was a right ventricular thrombus. So we wanted to rule out the PE. And the D diamonds were high, but they are expected to be high in malignancy, but then we wanted to rule out that.
My questions are very specific. In this patient, then you have a RB clot. Patient becoming hypoxic. It's infective endocarditis. So what value CT thorax or CTPA is going to add for your decision making?
It helps in thrombo. Anyways, we cannot do in this patient.
Okay. In CT pulmonary angio, you find in CT pulmonary angio, you find a clot which was in RV is now wedged to the pulmonary artery. Okay, what will you do now?
We can try for catheter-directed thrombectomy.
Sorry?
If patient is hemodynamically unstable, if at all there is a large clot burden, we can go for the catheter-directed thrombectomy.
Catheter-guided thrombolysis.
Yeah, thrombolysis.
Dr. Rose, would you like to put some light on this issue?
Yep, actually, yeah, in this issue, Sarit asking particular how it is helpful, whether it is changes your management, whether you will go for any anticoagulant, whether you go for a thrombolysis, whether you go for a thrombectomy. So are there any indications for this in a presence of right ventricular infective endocarditis, right-sided infective endocarditis with a large vegetation?
In case of acute PE, when the patient is hemodynamically unstable, it might be having a role. So if there is an acute PE.
Yeah.
Acute PE and acute infective PE, are they both same?
No.
Acute PE.
Acute pulmonary embolism, which is clot, or acute infective pulmonary embolism, which is infected bunch of billions of bacteria. Are they same?
No. No.
These are all called septic embolism.
Are you suspecting it is a normal pulmonary embolism or septic pulmonary embolism?
Septic pulmonary embolism.
Septic.
How you are going to treat septic pulmonary embolism?
Antibiotics, and if at all it is not, if it's more than one embolic events in 7 days, in spite of giving antibiotics, then surgery is indicated in those conditions.
Yes.
So then again, same question. Why did you CT scan in this patient?
To rule out the other causes
Pneumonia
like pneumonias and pneumonias in this patient.
Where is justified in moving this patient who was breathless to CT scan and giving contrast?
Because already in the echocardiography, you found that patient is having a large vegetation. And already you are saying that it is infective endocarditis. And by doing this, and you are suspecting a septic emboli, then immediately going for a CT by taking so much of risk, and your management is not going to change. So accept surgery. So why to take so much of risk and shift the patient for a CT scan?
Did you got my question?
Yes.
Yes, sir. Yes, sir.
Okay. Then you ask your teacher, I was asking this, what should be the answer? Or read it. Because these are the something which kids do not learn, because you need to learn these basic things. Overdoing in ICU is always dangerous than doing under. So you have to be very, very careful. Because whatever intervention we do in ICU, everything has a pros and cons. So if you do something which is not needed, and if it is harmful to the patient, and the principle of ethics come, first do no harm to the patient. So that's why especially I'm asking, when you know this thing, why do you want to do CT scan? And if you are looking something specific, is fine. Just for doing CT scan, taking this much of risk, doing CTPA in unstable septic patient, giving contrast, is it justified? And if you are getting any information which can change the outcome of the patient, is fine. If you are just doing CT scan, moving just for information, then is it justified or not? You need to understand this. Okay, go ahead, please.
On the day 3, this is a culture report, which detected to be MRSA, Staph aureus, which was sensitive to vancomycin and teicoplanin and linezolide. The patient was already on meropenem and vancomycin. This is
how much vancomycin you were giving?
Meropenem 2 gram TID was given, sir, and vancomycin was given 500 mg. TID was given, BD was given.
How do you give vancomycin, and what is the dose, and how do you monitor the effect of vancomycin in MRSA endocarditis?
Vancomycin
trough levels.
trough
30
levels
mg
has
per
to be
kg
seen.
per day.
Sorry,
That
one
30
person
mg
answer.
per
Either Tejasree answer or Sahitya answer. Who wants to answer? First you decide.
30 mg per kg per day in a 2 divided doses. We need to give vancomycin, sir. For assessing it, we need to take a trough levels of vancomycin. Just the sample should be taken before giving the next dose of vancomycin, and we need to target around 15 to 20 of the trough levels.
10 to 15 micrograms per ml.
So, Dr. Sahitya, you agree with that? The way Tejasree is saying, I want to add something in vancomycin for endocarditis. So, this was exactly given, or you have told your version?
No, trough levels are 10 to 15 micrograms per ml, sir. It is given.
Was vancomycin given in a unit like this, or you have told like you are telling your version?
No, sir.
So it was given like that only. Trough levels also we checked after giving it.
It's not possible. I cannot trust you on this. You need to go and see how vancomycin was given. If you do not know how to give vancomycin in endocarditis, better to go read better. It's a very serious issue. You do not know how to give vancomycin in endocarditis, then it's a dangerous issue.
We have to give it slowly, so just to prevent that red man flushing.
You are committing one more, and your mistakes. You know, like it's a wave of falling trap. So just once you have committed mistake one, accept and correct it. If you keep on repeating the mistakes, you will not learn. So whatever you have told about vancomycin is not acceptable to me. And Dr. Saroj?
Yes, sir. Yes, sir.
Are you okay with whatever they are telling in vancomycin?
Vancomycin, yeah. So what Dr. Tejasree told, that 30 mg per kg body weight, the loading dose to be given, and trough
Yeah, I mean, you are. What I am just asking, what they told, are they right, or they need to correct themselves in vancomycin?
Yeah, vancomycin dose, that is 30 mg per kg is right.
So what I wanted them to know, that for vancomycin, when you are giving for endocarditis, you need to give a loading dose of vancomycin, first thing.
Yeah.
And after loading dose, to get better result, you decide the total dose, maybe 30 milligram, whatever you have decided, and that you give over 24-hour infusion, not as a BD or TDS or 500 BD, what you are telling. So most of the time in current situation, particularly in endocarditis, many a time we end up giving around 2 to 3 gram vancomycin per day for endocarditis. And that precisely the reason, as an infusion, that precisely the reason you have to look for the serum trough level, because we are giving infusion, stop infusion for an hour, send sample, and again start reinfusion. The first loading, 24-hour infusion, look for the trough level, and then if needed, you can give even higher dose. So 2 to 3 gram is the dose which is needed. In endocarditis, we target at higher level because your requirement is, vancomycin requirement is high. So the only concern is if you do not give intermittent bolus, because it has side effect and its efficacy goes down. The vancomycin is one drug which is highly water soluble, which works on the T above MIC principle, but it should be continuously maintained above the MIC at least 4 times, because particularly the MRSA, if you do not maintain the serum level or any endocarditis, you will not get proper result. So for vancomycin, that's what we follow. And I believe that most of the people follow about vancomycin, that it is being given as an infusion, not as a intermittent bolus. But first dose you have to give as a loading. The loading dose is around 10 to 15 milligram per kg. That mostly 1 gram, 750 to 1 gram as the loading dose comes. Just see the dose, and then followed by total dose you divide over 24 hours as infusion. So once you give 1 gram loading, another 2 gram you give infusion. See the serum level, and the subsequent dose you can decide 2 gram, 2.5 gram, and even 3 gram as infusion. So many times we end up giving, once we check the serum level, up to 3 gram infusion in particularly endocarditis cases, because their requirement is very high.
Yeah, 20 mg per kg, the loading dose, sir.
Yeah,
Yeah.
this one.
Yeah.
Most of the time we give around 1 gram loading over 4 hours.
Yeah.
And then next 2 gram we give as the infusion.
Yeah.
In first 24 hours. We check for the serum trough level after stopping 1 hour. And once result, by the time we start same dose as the infusion 2 gram, and then we change the dose according to the trough level if needed. So for vancomycin endocarditis, you need to check the trough level very frequently, because and then because we are giving higher dose, and endocarditis itself has a chance of causing renal dysfunction because glomerulonephritis is fulminant. You need to be very, very careful about the urine output and looking for the renal perfusion and renal function. Okay. So what we are talking about in ABG?
That was the ABG on NIV, sir, in day 3.
Okay. So lactate is high.
Lactate was increasing. Lactate was 3.
Yeah, that shows that I mean, whatever we were doing, things were not working. Patient is getting more alkalotic, more, and they were giving NIV. So he was I mean, CO2 was out was more. Anyway, next.
So a patient was diagnosed to have septic thrombophlebitis causing right-sided infective endocarditis and septic pulmonary infects, and was
So why did you continue meropenem when things were MRSA positive?
So, MRSA one.
And the next question is, how do you treat MRSA endocarditis apart from vancomycin? What else you need to give?
Normally, beta-lactams, antibiotics plus aminoglycosides can be given, sir. Beta-lactams in case of 4 weeks and aminoglycosides for 2 weeks should be given. Or vancomycin.
I'm asking very specific question. How do you treat MRSA endocarditis, particularly right-sided endocarditis, which is acute infective endocarditis? So what is the treatment regime for it? Are you okay with vancomycin? You want to add something else?
Vancomycin and vancomycin, daptomycin, and nilosolide can be started, sir.
You want to start all 3 together?
No, these are the treatment for MRSA, but then vancomycin monotherapy can be given in case of MRSA native endocarditis.
Are you sure?
No. There are reports of meropenem monotherapy and meropenem and daptomycin therapy.
I'm asking again very specific question. How do you treat MRSA endocarditis when it's MRSA positive? First thing, why do you need to give meropenem? And second thing, are you okay with one drug endocarditis to treat RBIE?
We need to give a combination with the aminoglycoside, sir.
कहाँ पढ़ा है आपने? Where did you read it?
European.
So this was already sensitive to vancomycin, so maybe vancomycin plus.
मैंने कहाँ बोला नहीं sensitive नहीं है? मैं तो आपसे पूछ रहा हूँ. Are you happy with vancomycin? You want to add anything else?
Vancomycin monotherapy, we were happy, sir. So that's why we continued.
Look, I am not happy. Okay, go ahead.
We repeated the blood culture after 2 days, which showed MRSA again. Patient had continued to be in the day 4. Patient had continued to be hypotensive in spite of aggressive fluid resuscitation and vasopressor support. So day 4, the patient was intubated and started on mechanical ventilatory support. Patient developed severe metabolic acidosis and there was decreased urine output also. This was the ABG of day 4. There was severe metabolic acidosis with lactates of 19. The potassium was increasing 5.3, and there was decreased urine output with increased serum creatinine also in the lab reports.
How did you confirm that MRSA from the culture?
There was culture. So there was a culture which we have seen, which we have shown
on day 2.
And then day 4 also we did. It was same MRSA with the same sensitivity patterns. Normally every 24 to 48 hours we have to repeat. We repeated the second day.
Okay, but I didn't see the oxacillin actually resistance there in the culture report. Usually you look for oxacillin resistance pattern.
Yes, sir.
So in that culture report, I was just searching for oxacillin. Oxacillin resistance was not mentioned there actually. Okay. So how much oxacillin MIC level more than what you will say that it is having MRSA?
More than 4 micrograms per ml.
Yeah. So at what means when you told that there are options for your other options for treatment like vancomycin, daptomycin, linezolid. So when you will consider your vancomycin as a single drug or any other combination of the drug or alternative to vancomycin, daptomycin or linezolid. So when you will consider? Suppose you don't want to give vancomycin, you want to give daptomycin. So when you will consider? If your vancomycin MIC level is more than 1, so in that scenario, you can consider for a daptomycin, that to 10 mg per kg body weight can give for a daptomycin. And what any other combination of the drug you can consider for treating this MRSA, that to vegetation on the right side. Is aminoglycoside or any other drugs? What is the role of rifampicin?
Vancomycin from
Yes,
rifampin for 4 weeks in case of prosthetic wall.
Yes, sir. In case of prosthetic valve.
Any studies you know regarding that?
Yes.
Okay, no. So just you have to read what are the different combinations or any other combination which is
read about 2-3 bugs which are dangerous in ICU like MRSA, MDR, Pseudomonas. I'm not in general. I'm talking about read those bugs from good microbiology and medicine book to how to manage those bugs individually. So particularly MRSA, Pseudomonas, Acinetobacter, Klebsiella. There are the few bugs which are dangerous. Then in fungus, Candida aspergillus and Euchre. So these are the 5, 7, 8 bugs which can make your life difficult when they are sensitive. So you need to understand the microbiology of these bugs, their sensitivity. When you need to combine, particularly endocarditis, in any endocarditis except native wall endocarditis, very where the MIC were low, except that single drug hardly works. And for MRSA, it's very, very difficult situation. So all these things you need to really learn, read properly. Okay. So did you see in the treatment card, same thing was given or you missed the treatment card?
Same thing only was given.
So did you have taken out treatment from the treatment sheet?
Monotherapy was given.
Sorry?
No, meropenem and vancomycin, both of them.
Was it a real case, no?
Yeah, sir. I
Yes,
was
sir.
there
Yes,
that
sir.
time. Meropenem and vancomycin.
If it is a real case, then you have taken out this from your treatment card, isn't it?
Yes.
Yeah, treatment sheet. You have taken out the treatment from treatment sheet, isn't it?
Yes, sir.
So just saying you go back and think over that, what else you could have done in treatment for this patient. Okay, so go ahead. Next.
That's all. The patient succumbed to illness on the next day because of refractory septic shock.
So you can stop sharing. We can all come and go. So why RV endocarditis is different from left ventricular endocarditis? And why endocarditis per se is difficult to treat in comparison to any other infection?
Because of the complications. In the left-sided endocarditis, we see stroke.
What is the prerequisite for any antibiotic to work on bugs?
The penetration is difficult in case of this endocarditis.
Why?
It consists of platelin and fibrin layer along in the
Yes.
vegetation. So it is difficult. That is almost a layer over the bacteria, so that prevents the proper penetration into the bacteria.
Great. And one more thing to that. You need a serum level of antibiotic to reach. So it's not a static thing. It's a moving, blood is moving. So to maintain the serum concentration of antibiotics in a moving mobile structure, another difficult target. That's why if a tiny structure which looks like tiny, it has a billion of bacilli and they keep on soaring. So when this is, ideally when you have such kind of big clot and bad thing, the clot is full of infection. Many a time one can think of, either, because if you keep on giving antibiotic, it's not going to work. And if the clot is so, because thrombocytopenia and all the complication is because of that only. So one has to look for the thing that if you can remove, it's like removing the source of sepsis, though complicated, but in this patient. But otherwise, just giving antibiotic with this kind of, first thing to prevent this kind of complication is always possible. But once this happens, it's a very difficult situation, because no cardiac surgeon would like to put his hand in removing this clot and retrieving the clot. It's a problem. And just for a moment. Give me 15 minutes, I call you back. I'm just in a class teaching. So, but what you need, he said, Raja, give me 15 minutes, I call you back. So what you need to understand that achieving serum concentration of antibiotic is important. But whenever there is a big thrombus on right side, if the vegetation is okay, big thrombus on right ventricular, and that is causing sepsis, is a very, very difficult situation. It can embolize, it can cause fulminant sepsis, it can clog your right ventricle, causing complete low cardiac output obstruction. Anything can happen with this kind of clot. It can completely block your pulmonary embolism, typically causing septic thromboembolic phenomena where completely blocking your circulation. So everything is possible with this kind of clot. So when you do initial assessment, if clot is mobile, nowadays, even intervention can be done to remove those clots, even from pulmonary artery, even from RV also. So everything is possibility, but what is most important, you have to understand that when there is a catheter in immunocompromised patient, the first thing you will think if this sepsis is a right-sided endocarditis, if it is acute endocarditis, it is emergency. Most of the time, we forget, but treatment for acute endocarditis is surgical intervention. While SABE, you have time to give antibiotic. While acute bacterial endocarditis, most of the time it is surgical intervention which can help. But still after surgical intervention, the mortality is very high in acute bacterial endocarditis. But if you don't do surgical intervention, mortality is even higher. So one has to choose between well and ditch, where you want to jump. Somewhere you have to jump like that. But with long-term catheter, removing catheter, that's why initially I asked, Whenever a skin lesion, you think that Staphylo or Strepto is the bug. So you are saying basically, so all these are correlated. But read a lot about MRSA per se, because MRSA pneumonia, MRSA endocarditis, or any kind of MRSA infection has a bad prognosis. Dr. Saroj,
Yeah.
you. Over
Yes.
to you.
Yes. Yes, sir. And so what is the role of TE here? Already you have confirmed with the transthoracic echocardiography. So any role of TE here?
No role of T.
Right-sided, no role.
Not right. So it's already confirmed. I mean, we already seen the thrombus in the TT, so there is no role of T. Unless and until there is a new onset, again, cardiac complications or heart failure, which is not responding to medical therapy. In those conditions, you can expect T. But then here it's already confirmed, so TT will be fine.
Would be fine. Yeah, if it is confirmed, your specificity is good, almost 100% it is confirmed. So unless patient is having some complication, any paravalvular abscess or any complication related to the vegetation at the site, so that point of time you may need, or if patient is not responding to the treatment and having persistent fever and blood cultures persistently showing some same organism, and in that situation, again, we need to find out what is the other reason. For in that situation, probably you need to do a, even though it is confirmed with a transthoracic, we need to do a TE. Where any situation where you can directly go for a TE without TT?
Especially post-prosthetic wall conditions where the infection would be not seen in TT. So there'll be perivalvular the infection will be starting in the perivalvular region. That would not be seen in the TT.
Even with negative TA and there is a high suspicion of infective endocarditis, we can go for TEs.
Or yeah, one is prosthetic wall or prior history of infective endocarditis. Another is situations where your patient is having morbidly obese, chest wall deformities, or patient is on mechanical ventilation where it's difficult to get the windows. There directly you can go for a TE instead of TT, transthoracic echocardiogram. So is this patient fitting into your criteria, modified Duke's criteria for your definitive diagnosis?
Yes, sir. Two major criteria are fulfilled.
So what are the two major criteria fulfilled?
Blood culture, which will be consistent with the organisms which are responsible for IE. Here, MRSA Staph aureus was the organism. And second one will be endocardial involvement in form of maybe intracardiac abscesses or vegetations or new onset any regurgitation. So this was there. There was new onset TR was present and there was tricuspid wall vegetation. So in that way, two major criteria was fulfilled.
Any minor criteria are fulfilling in this patient?
Fever more than 38 degrees Celsius, that one, and vascular phenomenon, that is septic pulmonary nodules were present.
Yes.
So two minor criteria also were fulfilled.
And predisposing factors also present. Okay. Suppose in this patient, the organism is not Staph aureus, it would be Klebsiella. For example, if this patient blood culture is showing Staph aureus, because for infective endocarditis, say typical organism like Staph aureus and Streptococcus and other group of or HESEC group of organisms or Enterococci, these are the usually common organisms. Besides that, suppose it would be Klebsiella. Do this patient fit into this category as a major criteria?
It will be coming under minor criteria. Minor criteria is a microbiological blood culture, which is not under the major criteria. I mean, the organisms which are there in the major criteria. Other than that, the organisms comes under the minor criteria.
Yeah, minor criteria. So in that situation, you can consider one major criteria like that is vegetation you found in the echocardiography. Another thing you can consider in the, if it is organism is different from your typical organisms. Okay. So what are the scenarios where you will get your culture, when culture negative endocarditis?
In slowly growing organisms like fastidious organisms.
Yes.
When you will say culture negative endocarditis?
So where the culture is negative, but still there is a high suspicion of endocarditis, like there is endocardial involvement, or if there is a predisposing condition, there is immunological phenomenon, vascular phenomenons. That is, there is, according to the
minor
criteria,
threat.
there is high suspicion, but the blood culture is negative.
That's a negative.
Or if the patient is having, even if the patient is having vegetations, but blood cultures are negative.
It's a negative.
Negative for waiting for what period of time you will wait to say that it is culture negative.
72 hours.
There will be some incubation period. You need to wait for to say that it is culture negative.
72 hours we have to wait.
No. So minimum of 5 days. Minimum of 5 days you need to wait for to say it is culture negative hepatitis. Okay. So what are the common causes for that?
Coxiella, Legionella, Chlamydia, Aspergillus,
Chlamydia.
Mycoplasma,
And also fungi,
all fungi,
Candida, Aspergillus.
Streptococcus mitis, even that.
So those organisms, intercellular organisms, which are difficult to grow in the routine culture media, so it may be difficult to diagnose. So in those situations where you have a vegetation or you have a high suspicion, but your cultures are negative, in that situation, you need to evaluate for this. So for Coxiella or for Brucella or for Bartonella or this type of organism, suppose you want to identify, so either a serological test or a molecular diagnostic test you need to do for confirmation of your diagnosis. So in this patient, was there any indication for surgery? Sir already told.
Acute.
So I will just further reinforce this question.
Yes.
What is the indication of surgery in right-sided acute bacterial endocarditis?
Right side, if
Vegetation
the
more than 20 mm size of vegetation. A patient with uncontrolled infections like abscess, paravalvular leaks, patients with heart failure, which is uncontrollable, lining up with cardiogenic shock.
more than 7 days of prolonged bacteremia also, sir, if
Yes.
it is not responding to the antibiotic therapy.
So did this patient need surgery?
No indication.
Vegetation size we did mention.
Sir, please go ahead.
Yeah. So, so is there any difference between your indications of surgery from the left side, from the right side?
The size of the vegetation, so right side vegetation, it has to be more than 20 mm for that to be taken up for surgery, and left side more than 10 mm of vegetation also, in the, especially if it is in the anterior mitral leaflet also, it has to be taken up for surgery.
Yes.
So besides that, your other complications, suppose patient is having any paravalvular abscess or any root abscess or any leaflet perforation or any this type of severe regurgitation, valvular regurgitation or any complications are there, then those things are also an acute indication for a surgery. So in this scenario, what is the role of CT scan here? CT, or nowadays even the modified Dukes criteria also, they have included a FDG PET CT and CT scan. Is there any role of CT or FDG PET CT?
This patient, no role.
This patient no also.
So you have a strong suspicion patient is having a scenarios where you have a patient is having persistent fever. You are suspecting a complication. You are giving proper antibiotics. You have given for more than 5 days or 7 days. Patient is totally not responding to your, and you are suspecting some complication or a root abscess or a paravalvular abscess, but you are not finding in the transesophageal echo. So you have confirmed with the transesophageal echo, but you are not finding it. So in that situation, your CT scan will be helpful for particularly paravalvular abscesses. Any clinically you can detect, give a clue that patient is having a paravalvular abscess or a root abscess. clinical clue, or you do some test and you can get a clue that patient is having abscess. Because any patient is having a either right-sided vegetation or a left-sided vegetation, or suppose a aortic root abscess or something is there. So how will you confirm, get some clue?
If it is associated with regurgitation, then murmur.
Blocks, third-degree blocks.
Increasing in the murmur is not a clue. Actually, for that reason, that has been removed from your major criteria. Initially, that was a part of the major criteria. So now it is not strictly taken into major. Yeah.
Nuance at AV blocks.
Yes. So if you to take one ECG, yeah, if you take a ECG and if you are seeing that there is a prolongation of PR interval or first degree AV block or onset blocks, AV blocks. So in that situation, you should abscess, and in presence of clinical scenario. Clinical scenario is persist fever, this thing, clinical signs are there. So in that situation, you should expect that patient is developing some complication. And in that scenario, you went for a TE and you confirm the diagnosis, or do a CT and confirm the diagnosis, whether patient is surgical indication for the going for a surgery or not, you can take a decision. So in this right-sided, empirically, when you don't know the organism before culture comes, how will you manage this case actually? Antibiotics, how will you prepare empirical antibiotic? And after the culture reports, the specific antibiotics. So what will be your empirical antibiotics? Already for MRSA, we have discussed when you are already you got a Staph aureus and you are saying it is MRSA. So you are choosing an vancomycin. That's different. So I'm asking you, suppose you don't know the organism. So this patient had a right-sided endocarditis. So in this situation, if it is a native valve endocarditis or a prosthetic valve endocarditis, so what will be your empirical antibiotics?
Ampicillin with gentamicin.
Beta-lactam antibiotic.
Beta-lactam with aminoglycosides.
We have to cover Staph aureus, strepto, enterococci, and gram-negative aerobic bacilli also empirically if we don't know what the organism is.
Yes. So if usually the organisms which are common in a native valve endocarditis, the organisms which are common in a prosthetic valve endocarditis. So accordingly, you have to cover the organisms. So in a native valve endocarditis, what are the common organisms?
Staph aureus, BGS, viridians, streptococci.
Yes.
Then cons also, streptococcus viridioensis.
Yeah, cons is not a common in native valve endocarditis.
Prosthetic.
Enterococcus is also one of the common organism in basically two commonest organisms around that is Staph aureus and the streptococcus. And the third most common is enterococcus. So in that way, you need to cover the empirical antibiotics. Okay. And for a prosthetic valve, which is most common organism?
Prosthetic cons and aerobic gram-negative bacilli.
Yes.
So in that situation, which antibiotic you will prefer?
Aminoglycosides will be added, sir, and that will be, especially if it is prosthetic wall, beta-lactam antibiotics plus aminoglycosides for a longer duration of time. That is beta-lactam antibiotics for 6 weeks and aminoglycosides for the first 2 weeks.
Rifampicin is also added.
Okay. Suppose if you are getting a enterococcus in the your culture report is showing enterococcus fecalis, and that too it is community acquired, not any other source. So in that situation, what will be your preferable antibiotic?
Community acquired MRSA is little lesser common.
I'm asking enterococcus fecalis.
Go for beta-lactam.
Sorry.
What beta-lactam? You say the particular antibiotic. What is recommended antibiotic?
Nafcillin or
no.
Amoxicillin.
Enterococcus fecalis.
Amoxicillin.
No, it is ampicillin.
ampicillin.
Yeah, ampicillin with ceftriaxone.
Ampicillin.
So what is the dose of ampicillin and what is the dose of ceftriaxone?
Ampicillin 2 grams IV 6th hourly and
6th hourly.
Ceftriaxone 2 grams, 2 grams IV BDs. That is 4 grams per day we need to give in a divided doses. Ceftriaxone.
Yeah, but ampicillin we need to give around 12 grams per day. So 12 grams per day in divided doses you have to give, and that too in Enterococcus faecalis. So your duration of the treatment prolongs. So, and some of the organisms which are penicillin non-susceptible. What are the organisms which are MSSA? Suppose you are getting, if it is MSSA, it's okay, fine. And Streptococcus group of organisms which are penicillin non-susceptible. In those situations, you need to consider for some other antibiotic. So what are the antibiotic we will prepare in this situation?
daptomycin, linezolid. Okay.
Why daptomycin?
Which are not sensitive to penicillins at all, so only penicillins.
Yeah, non-susceptible to penicillin. So some of the Streptococcus, some group of organisms which are not susceptible to penicillin group. So in those situations, what you will prefer?
Fluoroquinolones or
No.
aminoglycosides can be given.
No. There also you can prepare a third generation cephalosporin, that is ceftriaxone. Ceftriaxone with the gentamicin will be more preferable in that situation. If you are getting a HESEC group of organism,
Cephalosporins can be given.
HESEC. What will be your drug options in HESEC group?
Cephalosporins only, so third generation cephalosporins.
Fluoroquinolones,
Quinolones, yes, sir. Quinolones are also given.
Fluoroquinolones,
For 6
ciprofloxacin
weeks.
or a
For 4 weeks
levofloxacin can be considered
Yes,
for a 6 weeks. So that's how you select. One is empirical antibiotic, another is after getting the culture report antibiotics you need to choose for that. But most important thing is your approach to the diagnosis is important here. So what are the changes you saw in this modified Duke's classification, means approach to the diagnosis compared to the previous Duke's?
They added imaging modalities, sir.
Mm-hmm.
Importance of PET CT, MRI comparative to the previous one.
Yeah.
And also endocardial involvement, if there's a new onset regurgitations or new onset heart blocks also. If there is no abscess, also if there is.
Okay. And so there is a role of CT scan or FDG PET scan was included in that. And the role of murmur, increasing the murmur, or those murmurs, it was not taken into consideration, not taken because it was there in the major criteria, but now still you need a echocardiographic or a CT guided confirmation of your diagnosis. And in this infective endocarditis, it is most, it's even though you in the critical care unit, we see rarely, particularly the left-sided endocarditis, but the right-sided endocarditis, particularly it is common in a critical care setup in ICUs because of most invasive lines, dialysis catheters and central venous catheters, and with the predisposing conditions in immunosuppressive state. And with critical care scenario, in that situation, we should have a high suspicion for different complications to these invasive lines. So, so how to suspect is important, and how to approach to the case is important. And then after diagnosis, confirmation about diagnosis, whether surgical indication is there or not is also important. So these things we should keep in mind and proceed to the case for the management.
Okay.
Yeah.
I think Dr. Prusty, thank you for that.
And
Rajesh sir.
just very quickly, one thing that many times we miss our thought, but whenever somebody, particularly in endocarditis, the surgical options should be explored early. Complications should be prevented. We should try to pick the diagnosis early. Many times sepsis, treating sepsis is different. Treating septic endocarditis is different ball game. You need higher dose, early surgical intention, removing all the probable sources. So a little bit when it is septic endocarditis, maybe it is left side, it is endocarditis which is acute. Shaibya do not come to us. To us, it will only come acute bacterial endocarditis. And when it is ABE surgical, it is a multidisciplinary approach, not only intensivist role. Take a quick help of your ID specialist because you may need a higher dose of antibiotic. Also take a help of your cardiac surgical colleague quickly because this patient needs surgical intervention very frequently to save. Otherwise, most of the time, acute bacterial endocarditis has a high mortality at 80 to 90%. So if you want to do that, you have to change your approach to save the patient. Okay, thank you.
Thank you, sir. Thank you for your valuable time and the wisdom you said. I think for students, most of them may not able to get the exposure of this infective endocarditis in routine medical ICU. But I think this case, which brought by both Dr. Sahitya and Tejasree, must have been given a overview to all the students, and there were a lot of queries and more than 100 students still hanging around. And we hope many thousand students by overnight will get the benefit of this. And I thank Rajesh sir. I know you have been tightly scheduled for your conference, and we are all waiting eagerly for that. In that tight schedule, you put the squeeze down for us, and for particularly students, sir, thank you so much for your presence, sir. It means a lot to us. And thank you, Dr. Prusty, for your valuable inputs and being a seasoned academician. Thank you for your presence, and thank you both Saiti and Tejasree for your presentation and your all through the patience and keeping the case pace on. Thank you all. I conclude the session. Thank you.
Thank you,
sir.
Dr. Venkat.
Thank you, sir.
Thank you.